Nasal cartilages. The cartilaginous dorsum consists of paired upper lateral cartilages and the cartilaginous septum. The upper lateral cartilages are overlapped superiorly by the bony framework for a variable distance. The free caudal border of the nasal bones has fibrous connections to the cephalic margin of the upper lateral cartilages. The cephalic 2/3 of the cartilaginous dorsum is a single cartilaginous unit. However, caudally, there is gradual separation of the upper lateral cartilages from the septum. The lateral borders of the upper lateral cartilages are rectangular in shape and are connected to the piriform aperture by an aponeurosis. The lateral border of the upper lateral cartilage creates a space known as the external lateral triangle. This triangle is bounded above by the upper lateral cartilages, laterally by the frontal process of the maxilla, and caudally the cephalic border of the lower lateral cartilage. The space is lined by mucosa and covered by the transverse portion of the nasalis muscle. It may contain accessory cartilages and fibrous fatty tissue that contribute to the lateral aspect of the internal nasal valve. Nasal obstruction may occur as a result of medialization of this space by scar tissue or cartilage grafts used in nasal reconstruction. ASCM, ascending maxillary process, LLC, lower lateral cartilage, NB, nasal bones, PL, piriform ligament, ULC, upper lateral cartilage. Blue, scroll ligament complex, red, piriform attachment ligament. Topographic landmarks. The Keystone area, where the nasal bones overlap the upper lateral cartilages, and the scroll area, where the lower lateral cartilages overlap the upper lateral cartilages. Restoration of the Keystone area anatomical structure during the primary rhinoplasty prevents open roof and inverted V deformities. The bony cartilaginous pyramid of the external nose is composed of three basic regions. The upper rigid third, the nasal bones constitute the upper 1/3. This part of the nose is pyramidal in shape, the narrowest portion being at the intercanthal line. The middle third, this contains the paired upper lateral cartilages and is referred to as the cartilaginous vault. The lower third, or lobule of the nose is further subdivided into the tip, supra-tip and infra-tip regions. These specific areas of the lobule are formed by variations in the shape, size, and angles of the lower lateral cartilages. Nasal deformities result from the loss of support to this tripod. The alar cartilage. The alar cartilage anatomy determines the surface aesthetics of the tip, and surgical techniques are performed on the anatomy to achieve the refinement that patients want. The alar cartilage is comprised of the medial, middle or intermediate, and lateral crura. They form two arches, with the medial crus converging in the midline and thus forming the columella, and the lateral crus supporting the lateral wall of the nasal vestibule. The medial crura converge in the midline, columellar segment of the medial crura, and diverge more inferiorly, toward the nasal spine, medial crural footplates. Posterior to their convergence and between them and the upper lateral cartilage there is an area not supported by cartilage, the weak triangle of converse, corresponding to the supratip breakpoint or depression. Lateral and caudally to the lateral crura, fibroareolar tissue lies between them and the piriform aperture, while laterally and cephalically, there are a few small accessory cartilages. The lateral crus is the widest part of the alar cartilage and is tightly adherent to the overlying nostril skin. The breakpoint represents the junction of the tip and the columella. The intermediate crura consist of a lobular and a domal segment. The intermediate crura are bound together by the interdomal ligament, and lack of intervening soft tissue may give the tip a bifid appearance. The lower lateral cartilages have been divided by Roland K. Daniel from medial to lateral, into three portions: medial crus, subdivided into a. footplate and b. columellar segments, middle crus, subdivided into c. lobular and d. domal segments, and lateral crus, e. The internal structure responsible for the prominence of the tip defining point, or pronasally, is the cephalic border of the domal segment of the intermediate crus. Thus, the shape, length, and angulation of the intermediate crura determine the configuration of the infratip lobule and the position of the tip defining point. The supratip breakpoint is the junction between the intermediate crus and the lateral crus. Vector of lower lateral cartilages. Note: green, appropriate, and red, not appropriate. The alar ring is defined as the entire alar cartilage and its continuation with the accessory cartilage chain. The ring begins at the footplates of the medial crura, passes through the entire length of the alar cartilage, and continues in the accessory cartilage chain toward the anterior nasal spine. The alar ring is quite flexible and undergoes dilatation or compression depending on the nasal musculature. One important point is that neither the lateral crura nor the accessory cartilages abut the piriform aperture. The alar lobule is devoid of cartilage, being composed of highly vascular fibroareolar tissue, muscle, and fat. Nasal ligaments. The anatomic term ligament is defined as a band or sheet of fibrous tissue connecting two or more bones, cartilages, or other structures. In 1971, Janik and Wright published a study on the support of the nasal tip in which they found the following four areas of anatomic support. 1. The scroll junction between upper lateral cartilages and lower lateral cartilages. 2. The lateral sesamoid cartilage complex. 3. The junction between medial crura and caudal septum, and 4. The interdomal sling. Subsequently, Tardy et al. Divided tip support into major and minor with the three major structures including the following. 1. The intrinsic integrity of the alar cartilages. 2. The medial crural footplates to the caudal septum, and 3. The scroll junction between the upper lateral and lower alar cartilages. Interdomal ligament. The interdomal ligament connects the two middle crura at the cephalic junction of the infralobular segment. Technically, the ligament does not run between the domes, but rather between the middle crura in a more posterior and cephalic location. Although many surgeons cut it during tip split procedure, Roerich routinely inserts an interdomal suture to narrow the interdomal distance, which in reality merely represents re-establishment of the previously cut interdomal ligament. Intercrural ligament. The intercrural ligament connects the cephalic border of the entire alar cartilages including the lateral, middle, and medial crura. It passes just above the mucosa and holds the alar cartilages together. The intercrural ligament unifies the two alar cartilages and acts as a suspensory sling over the anterior septum. Piriform ligament. Roerich et al. Has identified a broad ligament between the bones of the piriform aperture and the adjacent cartilages. The piriform ligament is probably a vestigial ligamentous sheet left over from absorption of the cartilaginous capsule between the periosteum of the bony piriform aperture and the perichondrium of the adjacent cartilage. Because surgeons have sought total exposure of the bony vault for piezoelectric surgery, it has become necessary to cut a portion this ligament. Scroll ligament complex. A longitudinal fibrous attachment has long been recognized in the scroll area between the cephalic border of the LLCs and the caudal border of the ULCs. Recently, Sabin and Pulselli identified a distinct fibrous attachment from the undersurface of the transversalis muscles to the scroll junction. The longitudinal scroll ligament occurs at the junction between the LLC and ULC and often has interspersed sesamoid cartilages within the fibrous tissue. Pitanguy's midline ligament. Pitanguy described a ligament originating on the undersurface of the dermis and running tangentially down to and in between the alar cartilages. He reported a connection between this ligament and the depressor septi nasi, DSN, which was later confirmed by de Souza Pinto. Recently, Sabin et al. Demonstrated that the medial SMAS at the level of the internal nasal valve divides into a superficial layer and a deep layer. The superficial medial layer runs caudally below the interdomal fat pad, but above the interdomal ligament into the columella. The deep medial layer of the SMAS runs beneath the interdomal ligament, but above the ASA into the membranous septum and then downward toward the anterior nasal spine. Sabin et al. Concluded that the deep medial SMAS could correspond to Pitanguy's ligament. Preservation versus transection. With a clear understanding of the nasal ligaments, surgeons must decide whether to preserve, transect, or repair the ligaments they encounter during rhinoplasty surgery. In primary rhinoplasty, one can achieve adequate exposure of the dorsum and septum with simple downward retraction of the alars, followed by a distal dorsal split in the area of the ASA. Preservation of the cephalic portion of the lateral crus with its associated ligamentous scroll attachment is possible in many cases. Automatic resection of the cephalic lateral crus should be avoided, as well as the creation of a standard 6 mm rim strip. An individualized approach should be taken, beginning with the question, can the entire lateral crus be preserved? For almost a century, surgeons have tried to achieve a desired tip shape by incision and excision of portions of the alar cartilages. However, the almost routine excision of the cephalic lateral crus can be associated with tip deformities, alar rim retraction, and external valve collapse. Preservation of the nasal ligaments during exposure is highly recommended. If transected, the ligamentous structures can be repaired as part of the tip suturing process. The most obvious example is the repair of Pitanguy's midline ligament. At the end of the surgery, the ligament is repaired, which pulls the soft tissue envelope downward, thus reducing the supratip dead space and potentially stabilizing the tip. BDET al. Has conducted quantitative measurements of the effect on nose tip support of several surgical techniques. Their findings show that the septum's relationship with the nasal domes through central suspending ligaments causes the nasal tip to be cantilevered, or nearly hanging, at the anterior septal angle. Merely disrupting this ligament-us framework led to a 35% reduction in tip support. There is no distinct fibrous attachment between the medial crural footplates and the caudal septum, nor is there a distinct ligamentous attachment between the accessory cartilages and the piriform aperture. However, the alar cartilages are joined together by the interdomal and intercrural ligaments. Rather than utilizing the fixed structural, tripod concept of the alar cartilages, another more dynamic concept of the tip is proposed. It begins with the intrinsic integrity of the alar cartilages, which are held together by ligaments. Thus, the alar cartilages are controlled by the SMAS and act as a dynamic structure that abuts the cartilaginous framework. Worth mentioned, there is no direct fixation or support between the domes and the ASA. Thus, the alar cartilages are dynamically mobile and can be surgically manipulated. We recommend that surgeons should consider preservation of the nasal ligaments whenever possible and utilize them to control tip projection, position, and rotation. Structural nasal tip support.